I request Dr. Balram Bhargava to come and give his talk on alcohol septal ablation and overview of technique and critical care. Dr. Balram Bhargava.
Come back, AP.
We should be thankful to Dr. Balram Bhargava for two reasons. One is,
turn this off.
yes, enlightened us with a new innovation talk yesterday, and second, in spite of his busy schedule where he has to go to Calcutta, we requested him to stay back and give this talk. He agreed. Thank you very much, sir. Proceed with the talk. Thank you.
Thank you, Dr. Srinivas. It is indeed a pleasure to be here and talk about alcohol ablation. I know we had a feast of this radio frequency ablation for renal arteries and hypertension. I have never seen it. It was really enjoyable. I'm taking copious notes and probably we will start that soon. Now let's come to hypertrophic cardiomyopathy. I'll give you a brief introduction how hypertrophic cardiomyopathy treatment was started and how we evolved it at the Institute, and some different technical points which will be useful. Now, hypertrophic cardiomyopathy is described by Hippocrates. He had described it in this form, that persons who had frequent attacks of swooning without any manifest cause dies suddenly. This was 400 BC. Then we all know about Brock's procedure, which is done for subpulmonic obstruction. Bloch in 1948 suggested that something of this kind exists on the right side. In 1948 he suggested this, and following which Tier in England, in London, did an autopsy series of more than 2,500 patients and demonstrated this hypertrophic cardiomyopathy the first time. And then the first clinical series was published by Longboard in Circulation in 1960. Slides back. Yeah. Okay, I'll change the slide. Yeah. Then the golden jubilee of alcohol hypertrophic cardiomyopathy is alcohol ablation, the gold standard. People have been talking about it. People have been debating about it. With the myomectomy, alcohol ablation, what should be done, and when should it be done. So it is a mysterious disease. And the patient has symptoms of chest pain, breathlessness, and also palpitations. So the cause of symptoms predominantly are because of septal hypertrophy and LVOT obstruction. There could be myocardial ischemia, there is diastolic dysfunction, there is mitral regurgitation, and many of these patients can present with atrial fibrillation. So the most important cause is septal hypertrophy and LVOT obstruction, and we know that from the earlier work by Balram clearly demonstrated that LVOT obstruction predicts the mortality over several years. Pharmacological management, we all know first line beta blocker, second line verapamil, third line is beta blocker plus verapamil or disopyramide. But now, if patients are still symptomatic, then they need to go for non-pharmacological treatment. And that is where we talk about alcohol ablation. When was this idea of alcohol ablation started? What happened was there was one patient of hypertrophic cardiomyopathy who developed an anterior wall myocardial infarction. And following that infarction, the paper was published in Chest in 1992, they demonstrated that the baby is disappearing. So that got the idea for people that alcohol, that ablation of that part, destruction of that part of the myocardium would be useful. Earlier, since 1970 till 1980 till 1990, myomectomy was the treatment of choice. Then there was some earlier experimental studies done by Ulrich Sigwart when he was in Switzerland, and inflated the balloon in the first septal artery and demonstrated reduction in gradient when prolonged balloon inflation was done. And this is a technique we often use to guide our alcohol ablation useful. So in 1994, they did the first alcohol ablation at the Brompton Hospital. They did 3 patients of alcohol ablation, and this was published in the Lancet in 1995. In December 95, we did our first case outside of the Brompton at All India Institute of Medical Sciences, and lo and behold, the 3 patients which were done by Sigwart all had permanent pacemaker implanted, and on our patient, we demonstrated for the first time that complete heart block develops, and the patient then required pacemaker, which was never revealed earlier as a treatment. So this is the technique, we all know about it. There are several names for septal ablation. The German group have named it in a different way. The Americans have named it differently. So basically it's alcohol ablation. The anatomic basis is the first septal unit. The first septal unit is the first septal artery, and that is supplying the septum. And we need to, as Dr. Narasimhan mentioned, that in 50% of the cases they found that it was more on the RV side. So you have to keep injecting several septals with not myocardial contrast but regular contrast. And on echo you can find staining, and this staining can demonstrate where the obstruction is. And then you can target that particular septal artery. This is an important, useful method for identifying the artery. Which patients? Patients class 3 or class 4 who are symptomatic despite optimal medical therapy. Left ventricular outflow tract gradient more than 30, as Dr. Narasimhan mentioned, that when there is no gradient, they would not like to do it. So it has to be resting gradients more than 30 and a provoked gradients of more than 60. And as I mentioned, there has to be the very suitable first septal unit. Contraindications are asymptomatic patients, we should not touch them. Patients who have organic mitral or aortic valve disease, patients who have existing coronary artery disease or valve disease and are requiring surgery for the valves or bypass surgery, they should be avoided. Very thin septa or very, very thick septa should also be avoided, because when the septum is very thick, more than 30 millimeters, there would be multiple small septals and it will be difficult to target them. Preferences are patients who have failed myomectomy or critically ill patients with LVOT, high-risk surgical candidates, patient preference, and centers where surgical myomectomy is not very well evolved. So I'll briefly talk about the technique. We insert a 6 or 7 French arterial and venous sheath. We insert a temporary pacing lead into the RV apex, and that has to be left there for 48 hours because delayed heart blocks are also well known. The LV angiogram should be done to demonstrate the obstruction, any mid-cavity obstruction, any mitral regurgitation. This does reduce alcohol after alcohol ablation. You do a coronary angiogram, identify the suitable septals, and measure simultaneous gradient. Eleocranial is the best projection, which is you show the septals on one side and the diagonals on the other side, so it's easy to identify the septals, but areocranial is good for cannulating them. We take a floppy tip wire. Earlier we used to take a long exchange length wire, but now we take a regular wire in over the wire balloon, take it there right up to the guiding catheter, make a extreme tip, that is a double curve on the guide wire, the small tip, the small bend, and then about 3-4 millimeters proximal to that another bend is made so that it goes into the septal. We take a short over the wire balloon, about 2 to 2.5 millimeters in diameter and 10 to 12 millimeter length. We do not take 6 millimeters or shorter because that has the chances of lemon seeding and jumping into the to the LAD proper, and that is the last thing we want to happen while injecting alcohol. As I mentioned, contrast echo is an effective strategy, and you can identify the target area, and by injecting contrast, regular contrast, which you're using for the angiogram, you do not have to use ultravist or sonicated contrast, but you just use regular contrast. You can identify the target area. You can see any remote perfusion if there is collaterals, and that is where you have to not do the alcohol ablation or avoid that septal. You have to see if there is any papillary muscle staining, because if there is papillary muscle staining and you cause an infarct, there will be severe mitral regurgitation, so you don't want that. Filling of other coronaries, if it is occurring, we have to be careful, and if there is filling of LV, you don't want alcohol to go into the LV. TE and TICE and TTE, we just use transthoracic echo, and that is very simple to identify the septum when it is stained by the contrast, and we can inject the alcohol. Now the balloon is advanced into the septal. Make sure there is no overhang into the LAD, there is no watermelon seeding, and it is completely in the septal, as distal as you can go. Because once you go very distal, the infarct size is not very big, and the arrhythmias are much less. So you repeat an angiogram and see that there is no movement. You pull out the wire and then inject contrast again and see there is no leakage. Now alcohol injection. remember one key point: use minimum amount of alcohol. 94, 95, we used to use 5 ml bolus injection, used to get complete heart block in most of the patients. And that was recommended at that point in time by the Sigward group, that just inject 3 to 5 ml alcohol, and sudden dramatic drop in gradient, sudden complete heart block, and the patient would definitely require a permanent pacemaker. The German group clearly predicted that alcohol ablation has to be as minimum, and that came as late as 2005. It took 10 years for the alcohol level to drop from 5 to 2 ml. And the formula for injecting alcohol is very simple. You take the size of the septum in millimeters and inject that amount of alcohol. Supposing it is 18 millimeters, you inject 1.8 ml of alcohol. If it is 23 millimeters, you inject 2.3 ml of alcohol. Just divide it by 10 and inject that amount of alcohol. After injecting 1 to 2 ml of alcohol over 5 minutes, you have to wait for 5 minutes for the alcohol to wash out, and then keep flushing, and then pull the balloon, because there would be some alcohol in the folds of the balloon, and you don't want that to go into the LAD. Intravenous analgesia, as I mentioned, for transient pain. Withdraw the assembly gradually, and then angiograms to demonstrate that they are. Sometimes you have to do more than one septal, and you may have to target 2 or 3 septals in the LAD, or we have done one interesting case where the septal was from the right coronary as well as also from the LAD, and we targeted both of them and then found a reduction in the gradient. Monitoring after the ablation, 48 hours in the CCU, watch for complete heart block, watch for right bundle branch block, watch for any ventricular tachycardias, and as I mentioned, the temporary lead has to be there for 48 hours, and you watch for CKMB rise. Now, what happens in the gradients? Basically, there are 3 phases that occur. One is the immediate infarction phase, where there's immediate drop in the gradient. Then there occurs the slight edema phase, when there is a slight rise in the gradient, and that is for about 1 to 2 weeks, following which there is the fibrosis and the scar formation, and again the gradient falls over several months. So let us talk about what are the clinical outcomes. 42 studies have been done with about 3,000 patients, mean follow-up of 13 months, with 89% procedural success and 7% required repeat alcohol ablation and 2% required surgery. There was dramatic improvement in NYHA class, Canadian class, peak VO2, exercise capacity at 3 months and at 12 months in most of these studies. And this was maintained up to 24 months. What are the complications? When we start alcohol ablation, we have to be very, very careful. As I mentioned, identify the right septal, minimum amount of alcohol, wait before deflating balloon for at least 5 minutes, and keep flushing when you take the balloon out. So what are the issues? In-hospital mortality can be anywhere from 0 to 5%. It is now 1% in most of the recent series. Complete heart block 0 to 40%. Now it has come down to less than 5% by several techniques, which I will talk about. Coronary dissection has been described in about 4% of the cases. Pericardial effusion, ventricular fibrillation, nominal. Coronary artery spasm, nominal. Important to see that right bundle branch block can occur in up to 2/3 of the patients, and left bundle branch block in about 15% of the patients. So the people looked at the anatomy after this alcohol ablation, where the septals apply. Earlier, the septal was proposed in earlier studies that it supplies the left bundle. Then they demonstrated that it supplies the rami septi fibrosis and can supply the AV node. So the septal supply to the AV node has been objectively shown by gross studies, anatomical dissection, and also by studies by resin injection, where that it supplies the AV node. So you have to be very careful in injecting alcohol in the right septal. Right bundle branch block is very closely related to this first septal. So you may sometimes have to go to the second septal or the third septal, depending. The important thing is when we do an LV angiogram with contrast in our RAO view, we let the cine run for a longer time. The LV contrast goes into the aorta, fills the coronaries. At that point, you identify which septal is supplying that hypertrophied part of the muscle. That is a very useful indicator for identifying which septal. Predictors of complete heart block, this is an important point. If there is existing left bundle branch block on the ECG, do not do alcohol ablation, because RBB occurs in up to 70% of the patient. If more than 2 septals are injected, there are higher chances of complete heart block. If bolus and large amount of alcohol is injected, if there is first degree AV block already, and in females gender, these have been the predictors of complete heart block, with the odds ratio of bolus injection 51 times higher chances of complete heart block. Female gender 4 times higher because they have smaller arteries. So you have to be careful in the amount of alcohol. Now once there is a scoring system which you can refer to in the in Journal of American College of Cardiology, where they've said that if the high risk score is more than 12 and low risk score is more than 8, and this is once you monitor the patient in the CCU, baseline PQ, baseline heart rate, baseline, they've given points for that. So it's not a very practical system, but in the CCU this can be used. Now left bundle branch block occurs in surgery, we have to remember. It is in 2/3. Right bundle branch block occurs in alcohol ablation in 2/3. And therefore, we had mentioned in 1999 in Circulation that complete heart block is unpredictable and it should be avoided in pre-existing left bundle branch block. And later this study came in JACC, where they showed that if alcohol ablation was done, the 70% would develop right bundle branch block. And if myomectomy was done, about 84% would develop left bundle branch block. So if there is pre-existing right bundle branch block, then alcohol ablation is a wiser thing to use, and myomectomy should not be done. There have been some studies which have shown that the benefit in mortality is more in patients who are older as compared to myomectomy, or it is similar when all patients are taken. When there are the younger patients, then the benefit is not that much. As I mentioned, amount of alcohol has reduced over years, and we have demonstrated clearly that reducing the amount of alcohol really reduces the number of complications, and mortality is directly related to the dose of ethanol, and therefore that 2 ml is the range where we would really like to stop, 2 to 2.5 ml if the septum is up to 2.5 mm in size. Now, how do you increase the outcomes after alcohol ablation? There was, as I mentioned, pressure guided. You inflate the balloon in the septal artery and then see the fall in the gradient in the correct septal, and also see for any arrhythmias or bundle branch blocks. This reduced the permanent pacemaker implantation from 30 to 10%. Myocardial contrast echo reduced it from 40 to about 5%, and minimum amount of alcohol is probably the most important predictor, and that has reduced the requirement of permanent pacemaker implantation to less than 5%. And as I mentioned, infarct size is directly related to volume and not the velocity of injection, and as I do not perform alcohol ablation in left bundle branch block. Problems with alcohol ablation, we have talked about procedure-related mortality 1 to 4%. Septal scar is an arrhythmogenic substrate. Limited cases have been shown with arrhythmias. We have not documented any such case in our follow-up. There have been some cases of late death and VSD. We have not had any such complication. Surgical relief, again, at the time of surgery, you can have myomectomy. You can also do the papillary muscle reduction. However, surgery has a higher success rate, lesser complete heart block, and mortality is slightly lesser, 0 to 2%. What is the comparison of alcohol ablation versus surgical myomectomy? There is basically 2 meta-analyses which have been published, and there is a need for a randomized trial, but I do not know whether this will happen ever. This is a meta-analysis of 5 case-control studies, and they have shown the LVOT reduction to be slightly higher with septal myomectomy as compared to alcohol ablation, while the NYHA class mortality are similar. Then they compared another meta-analysis which was just published last year of 7 studies, and they have shown that there was no difference in the mortality, no difference in NYHA class, and there was no difference in delta gradient. That if the earlier meta-analysis showed that there was a difference in surgical gradients, but the more recent meta-analysis showed that the delta gradient, that is the gradient you started with and what it fell to, the delta, there was no difference between surgery and alcohol ablation. So in conclusion, alcohol ablation is effective in the short and long term. It relieves symptoms and gradients, and Efficacy relative to surgical myomectomy is not known, but we clearly know that it is a relatively safe procedure with the minimum amount of alcohol use. Thank you very much. There are alternative therapies, and we've heard about 4 cases being done here at the Care Hospital where they've used radiofrequency ablation. Although radiofrequency ablation, there is only one study published from Germany, from the Kunz group, who have talked about reduction of alcohol. They've done 19 patients with showed marked reduction in gradients, maintained up to 6 months, but the requirement of permanent pacemaker was 21%. 4 patients did require a permanent pacemaker. So I will conclude with that, just to say that there are many ways men can be born, but his ways of death can be several. Thank you so much.
Thank you, sir. That was an extremely interesting and illustrative lecture. Thank you so much. Any questions? We can permit 1 or 2 before we go.
If there's a question?
One question.
So I'm Dr. Vijayan from Nasik. And last year we have done 3 alcohol ablation, and we wanted to see whether we are injecting the right artery in it, whether it is really that is the one which is causing LVOT obstruction. And we have tried both myocardial contrast.
Narasimhan, 1 minute, we'll come back. There's a question from you.
And even the routine dye, but we found that injecting intramyocardial contrast is much more effective because it stays longer and really gives you an exact picture of LVOT. And we were even worried whether it is going to supply the papillary muscle or it is going even distally, which then we should avoid. So I would suggest to use intramyocardial contrast with an echo guidance in the cath lab.
Absolutely, I perfectly agree with you and congratulate you for that successful case. And contrast is very useful and transthoracic echo to guiding where the obstruction is. Thank you.
Thank you. One more thing, what we have noticed during these procedures is nowadays we have this ICE catheter, intracardiac echo. We also would like to show some of the pictures recorded. It gives very good images. The advantage what with the ICE is the patient need not continuously have the TE probe, which is very intolerant to patients. So if once you place the ICE catheter, probably it keep on showing the pictures continuously without causing any inconvenience to patient. But I understand that is another costly transducer, but we tend to reuse it after.